Good afternoon, everyone. Can you guys all hear me? Yeah, no, I muted myself, but thank you for letting me know you could hear me. Okay, let me share my screen. Okay, you guys should be able to see the slide up now. And we'll give everyone just like another 2 minutes to log on to the webinar for today. Are you guys able to see the PowerPoint? Okay, great. So we'll get started at 2:02. I'm just going to give people a little bit of time to, you know, get on their computers and log in because sometimes people take late lunches, you never know. Okay, everyone, so it's 2:02 and we're going to go ahead and get started. I hope you guys all have had a wonderful week. So today is going to be our first official week of the study group. And we're going to be, discussing some of the chapters and we'll go ahead and just get started. Also, if you have any questions, just make sure you type it into the questions box. And if you do want to make any comments, you can raise your hand so that I can unmute your line. I'll try my best to kind of keep an eye out for that, but I think putting them into the chat box, into the questions box will probably be the easiest way to get my attention. So let's get started. Okay, so the agenda for today, we're going to do the practice 1 exam updates, which there's not a lot, and you'll see why. We're going to review the CIC study plan. So it's been approved. So you guys will be getting the CIC study plan today after the call with the follow-up email. We're also going to be discussing chapters 21 and chapters 22. We're also going to do a group member spotlight today, which will be new, but I want to just make sure that as part of this group, we're getting to know one another and that we're remembering, like we're all colleagues, and I think it's going to be fun to kind of learn about different people in the group. And then lastly, we'll review next week's assignments. Okay, so practice exam 1. I was not able to put together, all of the data because I unfortunately did not receive everyone's practice one exam results. So we'll have to discuss it at our next meeting. If you did not submit your practice one exam answer sheet, please submit it to me by close of business on Monday, because it will take some time to compile all that data, but I want to be able to share with you guys where we are as a group, like a baseline status, so that we can track our progress, because we'll be taking another practice exam in maybe like 2 months or so. And so I want to be sure that we're tracking if we're improving as a group. And I think it would just be really great to have that data. So if you did not submit it to me, please try to get that in to me by close of business Monday. So just set some time aside this weekend to get that done. Okay, so we're going to be reviewing the CIC study plan, and let me actually pull up the plan since it's ready for prime time. Okay. So this is what the document is going to look like when you receive it. So I spoke with the HAI program and also my program manager here at DOH Orange, and they felt that it would just be easier to share it as a PDF rather than having it printed. Since we've already started the group and it's going to take some time to get it done, that it's better to just let everyone have access to it so that we can get started and get working on it. But this is the CIC study plan, and I just kind of want to go through it so that you're familiar with what it looks like when you receive it in an email later this afternoon. So blah, 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 letter by me telling you guys, you're beautiful, I appreciate you, and I'm proud of you guys for, embarking on this journey. So like I told you before, we need to utilize this workbook and study plan in conjunction with the APIC text and the certification study guide. So this is not really a document that's useful if you do not have access to those other two study materials, because this plan is based off of that. And so I just wanted to, provide you guys a reminder in case anyone forgot. And so, the exam components right now for our first kind of module, or our first exam component, we're focusing on identification of infectious disease processes. And so that's what the next 4 weeks are going to entail. So this is what the study plan for the first 4 weeks looks like. You see here, our first week we had chapters 21, 22, and 23, and then this would be our first meeting on August 31st. I left the meeting date blank since hopefully this document can be utilized for future cohorts. Hopefully we will have future cohorts, and so it'd be, I didn't want to put the dates on there, making it essentially useless for future cohorts. For week 2, you're going to have to read chapters 24, 25, and 26. These are some really key chapters for the CIC exam. So I really want to make sure that you guys are trying your best to keep up with the readings. I know it can be challenging with working full time, and some of us, go to school, but it's really, really important to try your best to keep up with the readings so that you don't get too far behind, because that's when I feel like the exam can become a bit overwhelming, is when you start thinking, oh my goodness, it's over 135 chapters of material. Like, how can I actually be prepared for this? And so just try your best to keep up with the readings. And you'll see that I don't necessarily go in order. So, we're not going to go through chapters 1, 2, 3, 4, and then move on down. It's kind of more scattered because I wanted to be more focused on those concepts, which I felt and other people who took the test felt were extremely relevant. And so here's the study schedule. So at the end, oh, sorry, you have additional chapters as well. So for example, Danielle Rankin, she actually read all of the chapters in the APIC text, and she took her exam and she passed. Also, Kathy Abusagar from our first cohort, she also read all of the chapters in the APIC text and she also passed. But there were other members like myself and Milani Dickinson who we did not, specifically read every single chapter of the text, but we were also able to pass because we really had a lot of those core concepts down. So these additional chapters are chapters which are of course helpful in our recommended reads, And these numbers in parentheses are the total number of pages. So, you know, if you're like feeling extra lazy on a Saturday and you're like, listen, I am not about to give up this whole Saturday to read this book, you may just want to read, you know, these 4 pages on West Nile virus, or you may decide, you know, I don't really work with rabies. Let me learn a little bit about rabies. And so that's why I've put the pages here so that you're kind of able to decide what you want to read or what you don't want to read. At the end of each module or at the end of each section or component, there will be an assignment of completing the practice questions on the certification study guide. And so this is the spot for you to, you know, fill in your answers from the book, and then of course, get your percentage correct. These are the papers, or these are the sheets that you will be submitting to me. So when I request practice questions from pages 41 through 52 of the certification study guide, you'll answer this, grade yourself, send me the percentage correct, and then send that back. Because what that will allow me to see is, okay, what chapters from, or what concepts from these chapters did we miss and do we need to revisit? Um, so that's why we're going to be doing it at the end of every module. Does anyone have any questions so far? Okay, I do not see any raised hands, so we're going to move on. So this same format continues throughout the entire document. So for each module, you'll see we'll have assigned readings, then our practice questions. And so this is for every single, you know, component for the exam. Preventing and controlling the transmission of infectious agents. This is an extremely heavy, chapter-heavy version, or chapter-heavy module for you know, for this exam, and there's a lot of chapters that are involved. So I would really recommend that you let your practice exams guide you. You know, practice exam one guide you. If there were certain chapters that you didn't do well and consistently, making sure that if it's not part of one of the core chapters or assigned readings, to try to make some time to you know, to squeeze those into your schedule. So, you know, we keep going down, and it's for all the different components. When you get to the bottom, you'll find the answers and corresponding chapters for each section. So for example, this blue colored, that's for the identification of infectious disease processes. And so they're matching so that you're able to check your answers and also basically highlight the chapters which you may not have done well in, like tuberculosis, or, you know, antimicrobials, microbiology basics. That way you're able to basically figure out what areas or what topics you're still missing out on. And that's for all of the practice questions. When we get to the bottom is when we get to the practice exam one questions. I know it would have been so nice to have this, but you know, I had to wait to get it approved. And so this is what the practice exam one questions answer sheet looks like. And then you know, so people know academic dishonesty. So you guys would know that the answers are ahead. And then the answers are on this side, on these pages. And it's also attached to which chapter it's related to, so that you're able to, once again, see what chapters you need to review. So this is kind of the outline for the CIC study plan. It's a hefty document. It's about 52 pages long, but I hope that it's helpful for you guys in tracking your progress. At the end of our cohort, I will ask you to complete a survey on the CIC study plan, just to see, you know, if there's anything that we can improve on, anything that we can fix. And this is for not just group members, but also the participants. So that's it for the CIC study plan. It's pretty self-explanatory. You know, you go in order, and I'll let you know whenever you have assignments due. You won't have any assignments due for, you know, for 4 weeks, which is the next set of practice questions. So is everyone kind of ready to move on? If there are no questions, it's pretty self-explanatory. I'll just give you guys a sec in case you need to type something, and then we can just move on. No, I have not sent out the guide. The guide's gonna get sent out today at the end of our meeting. When I send I'm gonna wait for the recording to publish, and then I'll send it out all together. Actually, I may not wait for the recording to publish because it's not as important as the guide. So yes, Tanya, I'll send it out at the end of the meeting. Okay. Yes, it's going to be sent via email to everyone so that you're able to get it printed out and take it home with you and have it be your best friend for the next 6 months. Okay. Any more questions? Nope. Okay, I think we're good. So let's get started with chapter 21. And this is risk factors facilitating transmission of infectious agents. So this is one of the assigned readings for this past week. And the way that we're going to review these chapters is we're going to go over some of the key concepts in these chapters to just ensure that you have a good understanding of them. And then that's what we'll be doing every week. Patty's group in Washington is very question focused. So it gives you a good opportunity to put all of your knowledge into practice. And this is more for reviewing information and ensuring that these concepts are getting explained thoroughly and that you're understanding them because they're important for the exam. So the first thing we're going to discuss is the chain of infection. Now, this is very elementary, but it's very important for us to keep this in mind when it comes to infection prevention and control. This is the chain of infection, which is a document that was this specific chain was created by APIC, and I really like it because I think it's very fun and colorful, but it basically goes through all of the different components. So the infectious agent, which would be the bacteria, fungi, viruses, parasites, the reservoirs, which would be like dirty surfaces and equipments, people, water, animal, insects, soil, earth, like the ground, Legionella, water, Legionella. Okay, portal of exit, which would be open wounds or skin, splatter of bodily fluids or aerosols. The mode of transmission, is it contact, direct or indirect, ingestion, inhalation? The portal of entry, this is how the actual pathogen is, getting inside its host. So broken skin, incisions, the respiratory tract, mucous membranes, catheters and tubes. The susceptible host is any person, especially those receiving health care. Because typically if you're receiving healthcare, you're going to be in more of a vulnerable situation. You're not in the hospital because you're extremely healthy and you're there for a checkup. You're there for a reason. And so it's for people, specifically here in infection control, we're focusing in healthcare. Now, the reason why I really like this drawing by APIC is because little thunderbolts represent different measures that you can take to break the chain of transmission. And this is really the basically the like holy grail, the bread and butter of infection prevention. It's the chain of infection, because the entire time, every single effort that you're taking in an infection control program is trying to break this chain, whether it's with your environmental services employees, whether it's hand hygiene, proper donning and doffing of PPE. All of this basically centers around the chain of infection, which is why it's so important for you to understand it. So when it comes to the infectious agents, such as, the bacteria, fungi, diagnosis and treatment and antimicrobial stewardship are some of the measures that you can take into breaking that chain. For the reservoir, so dirty surfaces and equipment, etc., cleaning, disinfection, and sterilization, infection prevention policies, and pest control. This all has to do with breaking the chain of infection. Can you guys tell me a measure that you could take to break the chain of infection when it comes to reservoir and Legionella? What would be one way that you can actually break that chain? Okay, hyperchlorination. Anything else? Temperature regulation, very good. Okay, so the reason why I'm asking that is because, CMS has put out a notice on Legionella and ensuring that healthcare facilities have water management programs, and it's extremely important for us to just have these things in mind when you're taking this test is you're really thinking as an infection preventionist. I know a lot of us on this call work in public health or work in, other types of facilities and organizations, but when you're taking this exam, you really need to come at it from an infection prevention standpoint. And so, yes, of course, the things you guys mentioned would be good ways of breaking that chain for Legionella. We're going a little bit out of order here, but for the susceptible host, some methods for breaking the chain would be immunizations, right? So, for example, my dad is over 65 years old. So, one of the things that he has to make sure he gets is his influenza vaccine, right? Because one year he didn't get it and he got everyone in the house sick. And so, that's a way of breaking the chain of transmission, right? Treatment of underlying disease. If you're a diabetic and your insulin and your sugars are not well controlled and they're not well managed, or if you have obesity, or if you have COPD and that type of underlying disease is not well managed, that's going to affect, right? That's going to affect whether or not you're susceptible to getting an infection. Having health insurance, which ensures you have access to, of course, healthcare and patient education. And patient education was something that they really covered on, was it chapter 21? I think it was chapter 21 of the book. So if you guys have any questions about that, please make sure you reread because we're not going to dive into that today. Now for portal of exit, mode of transmission, portal of entry, there is, listen, there is one thing across the board, actually two things across the board, which help break the chain of transmission. Hand hygiene, personal protective equipment. Literally at every single step, every single link of the chain, hand hygiene and PPE are so extremely important for breaking the chain of transmission. So when the health department is out at healthcare facilities and we're conducting an infection control assessment, two of the main things that we are going to look at are your hand hygiene adherence rates, and not just in and out. So in and out meaning before going into the room and having patient contact, and after leaving the room and having patient contact or contact with the patient's environment. Um, but also the 5 moments of hand hygiene, which are the World Health Organization's 5 moments of hand hygiene. Those are some of the biggest things that we're going to be looking at because we know how big of a role they play in breaking the chain of transmission. For portal of exit, controlling of aerosols and splatter, respiratory etiquette. I cannot tell you how many times I have been at a healthcare facility and I have seen doctors, nurses, healthcare personnel just coughing into their hands and then going into the patient's room or just openly coughing in an area like in a hallway. And I'm just like, guys, respiratory etiquette, let's get it together. And so waste disposal, that's another way. For mode of transmission, once again, hand hygiene, PPE, food safety, cleaning, disinfection, and sterilization. I think that's the title of chapter 31 in the book, and isolation, right? So this is our transmission-based precautions, contact precautions, droplet precautions. So this is another way to break those chains. And then portal of entry, once again, hand hygiene, PPE, personal hygiene. They have an entire list of what personal hygiene entails for a patient. And so I hope you guys read that because it was really interesting. First aid and then removal of catheters and tubes. Okay, time for some questions. Okay, so these are some key vocabulary that we need to know as we continue our lessons. So for number one, virulence, what is the matching answer that goes with it? Getting some B's, getting some E's, getting some more E's, a lot of E's, all the E's. Okay. All right. So we got some B's in the beginning. So those of you who said B, congrats. Virulence is the ability to grow and multiply. Okay, for two, infectivity. What answer corresponds with that one? Getting some D's, some C's, some E's, another E, another D. Okay. All right. So it's D, infectivity, the ability to enter tissue. Okay. Next is 3, pathogenicity. So we've only have a couple left to choose from. So for 3, pathogenicity, the E's are back at it again. Okay, yes. That is E. Okay, and the last 2 are pretty easy. So for 4 is duration of exposure. That's going to be the length of time the person is exposed to the organism, and then size of inoculum, the number of organisms needed to cause disease, right? Okay, hope that was fun. So, some medical interventions that increase risk. So when it comes to infection prevention, you are going to have patients that are going to necessarily be very low risk patients, that don't have a lot of health issues that are there for, they may have had some type of episode, some health episode, but they're there, they don't have any indwelling devices, and they're kind of one of your lower risk patients. And then you're going to have your higher risk patients. And so some medical interventions that increase risk of, pathogens being transmitted to that person are going to be presence of invasive devices. And so can you guys type in what some invasive devices would be? Ooh. Catheter, central line, PIC, vents, Foley's, um, more central lines, trachs, very good. Yes. So those are some of the invasive devices. And the reason why it's going to put patients at a higher risk is because if you have any indwelling devices or invasive devices, you're going to need a lot more care. There's going to be a lot more involvement from healthcare personnel. They're going to be coming in and checking up on you, touching your environment, going from other patients' rooms to your room and making sure that, you're being taken care of. Placement in an ICU. Patients that are in intensive care units are typically in pretty bad shape. They're needing, around the clock care. They're being closely monitored. A lot of the times these patients have, been in traumatic accidents or have had, they've had strokes, they've had heart attacks, they're in really poor shape. There may be different reasons why they're in an ICU, but once again, they're receiving a lot of care. These patients sometimes have multiple lines. They are getting dialysis. They may have up to go to surgery multiple times, especially when you're dealing with these traumas. And so once again, they're at risk. Exposure to antibiotics or certain medications, immunosuppressive therapy, length of hospitalization. The longer you're in a hospital, the more likely you are to come into contact with some pathogens. The longer you're in a hospital, just the more time that there is for a healthcare personnel to make a mistake and to not practice hand hygiene, or for one of your family members or visitors to make a mistake. So length of hospitalization plays a role. Staffing ratios. Why are staffing ratios so important in basically the increasing or decreasing your risk of acquiring an infection? And that was a question. May forget hand hygiene because you're so busy. Nurses are rushed. There's less staff per patient. The more chances for mistakes. Exactly. Tired, busy, no time for hand hygiene. Yes, that's very good point. So staffing ratios are so important because when your nurses and your CNAs, and your medical, personnel are burnt out because their workload is so high, there is a much higher chance of mistakes being made, wrong medication being administered, you thinking that you're administering, Cipro when you're giving sulfasolin. Like there, different things could occur, right? And so medical errors are more likely to occur when you have less staff taking care of patients. That's why in the intensive care unit, you have higher staffing ratios, right? Because these patients are more critical and they need more care. They need nurses that are able to pay attention to them, providers that are able to devote their time to keeping them alive and keeping them safe. Um, Experience and training of care provider for certain device-associated infections, that's another risk. An increased number of healthcare personnel examinations and procedures, which we already discussed. Patient factors that increase risks of transmission of infectious agents. And so this is kind of a long list, but I think it's important for us to just kind of, I'm just going to go through the list, but these are things that you need to keep in mind when you're taking the test. So immunosuppressive diseases and disorders, malignant disorders, patient's acute physiology and chronic health evaluation score, poor nutritional status, age, right? Really young, they're really old, diabetes, pregnancy, travel history. And I know us who work in the health department and those who work in hospitals, travel history is very important. Occupation, residence, contact with certain pets or animals, extensive burn wounds, and trauma. So infection risk reduction. So what can we do to reduce the chances of infection? Adherence to appropriate infection prevention measures like hand hygiene, PPE, thorough cleaning of both high touch surfaces and the routine environment. These are all, that is the bread and butter of infection control. Hand hygiene, PPE, and environmental cleaning. You guys need to know it like frontwards, backwards. You need to know these chapters like chapters on hand hygiene, PPE, and chapter 107 on environmental cleaning, which will come later on, but these are really important concepts to have in your mind for when you take the exam. And surveillance activities. So some examples that the book gave for infection risk reduction are surveillance activities. So for example, SSIs or surgical site infections are reduced when a surgeon-specific healthcare-associated SSI rate is provided to the surgeon, right? That would be extremely helpful if you're a surgeon and you're being told, hey, these are what your rates are. It's going to give you a clear picture of, oh, I need to improve. Like something needs to happen about these rates because they're quite high. If you're surgical, if your general surgery, team is just told you have high, SSI rates, they're like, okay, well, we're doing bad as a whole. But when you're actually approaching surgeons specifically, then you're providing them with kind of motivation to improve their practices. Also, the UTI rate is decreased when the unit-specific healthcare-associated urinary catheter-associated UTI rates are reported to specific nursing units. So these were the two examples. That was a mouthful. I was supposed to put that in parentheses. I apologize. So these are two examples of surveillance activities. Okay, so I have an assignment for you guys to do today. Since we're talking about hand hygiene and PPE, there's a podcast that is extremely interesting and gives you a really good idea of what it's like to be a medical provider and dealing with, with a tough case, right? So a SARS case. And so this is a podcast, and in this podcast, it's the emergency medicine cases. You have a doctor, Dr. Lori, from Canada. She was working in Toronto back in February of 2003. She was working in the emergency department when a patient presented to the ED with extensive diarrhea. They were in respiratory failure, hypoxic, and extremely combative. So this is essentially a respiratory failure, respiratory distress code. And for those of you who worked in healthcare, you know that when a code is happening, it's extremely, the atmosphere is tense. You have physicians leading and orchestrating the code, and essentially working with whatever type of medical emergency is occurring. But another thing that also happens when you have any type of medical emergency or respiratory distress is that a lot of people are coming into the room. And so in February of 2003 was when the World Health Organization is sending out notices around the world, letting them know, hey, if you have any patients coming from China or Hong Kong to your emergency departments, you need to keep your eyes out for SARS, which stands for Severe Acute Respiratory Syndrome. And so this really combative and patient that's in respiratory distress presents to the ED with travel history to those countries. And so they're handling this case, right? And because he's extremely combative, there were multiple people in the room trying to assist. You had your RNs, your RTs, residents, physicians trying to intubate this patient and trying to, practice the best medicine that they can. And at that time, the people in this scenario, they were wearing double gloves. They were doing the double double. She refers to it as in the podcast, the double double, double gloves, double eye protection. They were having goggles on and face shields and double gowns, and everything was doubled, right? And so this gives you a really good idea of what it's like to handle these complicated cases from a medical provider's perspective, because many of us may not be nurses or may not be doctors. We don't, we may not have the experience to know what that's like. And so I think it really provides you a good picture and an understanding of what it's like to handle these tough cases, and it helps keep into perspective when you're providing recommendations, especially if you're coming from the health department perspective, when you're providing these recommendations of, make sure you're abiding to the proper PPE. But she talks about some of the downfalls and how actually healthcare providers ended up you know contracting SARS when taking care of this patient. And so, in order to get to the bottom of the story and figure out what happened and if anyone died and if any nurses died and, what the story is, just make sure that you go and listen to this podcast, because I think you'll find it extremely interesting. So for SARS, SARS is airborne, right? So it's being transmitted, through the air. And this is an image from a Coursera course, which provides you a really good idea of what these droplets look like when they're in the environment. And you always want to keep in mind disease transmission when it comes to the CIC. You're always going to want to think about how are these diseases being transmitted. And so it's just really important for you to just keep it in mind and remember these pictures and images when you're providing recommendations to facilities. I wanted to just briefly touch on Ebola virus disease principles of PPE. This is one of the pages on the CDC website. Since we were talking about SARS, I figured it would be appropriate to also touch a little bit on Ebola. And so, donning. Donning is so extremely important when it comes to dealing with Ebola. So PPE must be donned correctly in proper order before entry into the patient's care area, and it should not be later modified. And so with the SARS podcast, when you listen to it, you'll realize that the healthcare workers were getting very hot, and their face shields were fogging up, and so they were readjusting, right? They were having to readjust PPE, and it's, it should not be modified once you've entered that room, that airborne precaution room, like, or, in the case of Ebola, when you've entered that patient area, your PPE should not be modified, because that's when you're coming into risk of, acquiring a disease. For doffing, removing used PPE is a high-risk process that requires a structured procedure, a trained observer, a doffing assistant in some situations, and a designated area for removal to ensure protection. Now, that's specifically referring to Ebola, but when it comes to, your healthcare facilities, it's so important that you're observing your healthcare staff, or when you're doing a site visit because there's an outbreak of influenza or norovirus at a nursing home, that you're observing what those doffing practices are like, and that you're ensuring that hand hygiene is occurring after, because doffing is it's a high risk process, and that's when your healthcare providers are most likely to get contaminated, right? They've just changed a Foley, or they've just helped clean a patient, and they're removing those gloves. If they don't do it properly, they're going to come into contact with those pathogens. And in the case of Ebola, double gloving provides an easy way to remove gross contamination by changing an outer glove during patient care and when removing PPE. This is specifically for Ebola. I have seen a lot of double gloving in healthcare facilities and in nursing homes, and that's a practice that is not recommended by the CDC. So some personnel practices that you can take into account for, reducing your risk of transmission of infectious agents are immunization of your personnel needs to be required and available. And, here, of course, we're referring to influenza and other diseases hepatitis B, but primarily influenza. That's what you think about when you think of immunization of personnel. Restrictions of healthcare personnel with a communicable disease or infectious process, such as diarrhea, group A streptococcal infections, conjunctivitis, draining dermatitis, or exudative lesions, active TB, and possible infectious rashes. This little bullet point right here, bullet point number 2, you guys need to have this memorized, not today, not tomorrow, but by the time you're going to take the test, because you are going to get a lot of questions. You're going to get practice questions, and then you're going to get questions on the test, which are basically going to be letting you know, hey, you have a nurse that has this type of condition. They have a rash, they have conjunctivitis, they have a draining wound, a draining lesion, right? What kind of care are they allowed to provide, or what kind of precautions do they need to take, or should they be allowed to practice patient care, right? And so you need to make sure that when you're reading and you're learning about restrictions of healthcare providers, that you're keeping those in mind, and that you're starting to, from very early on, file them away in your brain for later use. Assignment of patients to be cared for by immune healthcare providers. So for example, only employees with immunity to varicella should be assigned to work with patients who have chickenpox or herpes zoster. And then protocols should be created for evaluation and follow-up of an employee exposure to infectious disease. And that has to do with occupational health. We have an entire module on occupational health, so we don't need to dive into that right now, but just to quickly review. Okay, so some true or false questions. So patients with the same airborne disease may share a room if there is no clinical contraindication. You can just put TRF. Don't type it all out. Save yourself some time. Good job, good job. We have the majority of people putting true. Now, we always want to try to ensure that we have an individual room, right? We try not to cohort, or try not to, cohort unless it's absolutely necessary. And so unless it's absolutely necessary, you are able to put, people with the same airborne disease that may share a room. So if you didn't have enough rooms and you had patients with, active TB, it was a family, let's say a wife and a husband, they would be able to share that room. And this was part of this was stated in your book. The next statement is cohorting of patients infected or colonized with a common organism by room or personnel assignments can reduce the risk of transmission of infectious agents to other non-infectious patients. True or false? Yes, we have a lot of truths. Wonderful. Yes, so we do know that cohorting is extremely important, and it is a key when you're trying to especially manage any type of outbreak in any type of healthcare facility, and so that is correct. And then lastly, increased HAI rates have been associated with the use of non-permanent staff. True or false? Yeah, okay, I was trying to trick you guys because when you're taking a test and you're like, oh, they can't all be true, but you guys are pretty good. Yes, and so this comes back to, it's the same thing as kind of staffing ratios. If you have staff that are not permanent to your facility or that are coming and going, more than likely they're practicing, in other facilities, right? So they're floating around. And guess what? The culture of every hospital, clinic, ambulatory center is different. You have some hospitals that are very patient safety driven, others that hope to be very patient safety driven, but their culture is not really centered around hand hygiene or PPE. And so as you have non-permanent staff going in and out of your own culture of your own healthcare facility, of course there's going to be an increase, HAI rate, because they may not be, adhering to all of your recommendations or the kind of culture that you've fostered in your healthcare facility. All right, so this was question 113 from the practice exam, and this was based off chapter 21. So the IP wants to calculate the surgeon-specific rate of infections associated with spinal fusion surgeries in the facility. Which one of the following data elements will he need? 1, number of spinal fusions procedures within the designated time frame. 2, number of spinal fusion SSIs within the designated time frame. 3, number of spinal fusion surgeries performed by each surgeon within the designated time frame. And 4, number of spinal fusion infections for each surgeon within the designated time frame. So we have A, B, C, or D. Okay, we have a lot of D's, an A and a C, but the majority is D, which is correct. Sorry. I'm just skipping ahead. I apologize. Yes, the answer is D. That is correct. The number of spinal fusion surgeries performed by each surgeon and the number of spinal fusion infections for each surgeon, because you're wanting to calculate the surgeon specific. Okay. All right. Listen here, Microsoft. So the surgeon specific rate of infections. So you're gonna want to focus around each like individual surgeon. So I hope that makes sense. Okay, next chapter. I'm gonna have to speed it up a little bit, because we gotta get this done. So chapter 22, we're gonna talk about microbial pathogenicity and host response. Okay, so infection versus colonization. So let's see what colonization is. I know we have to explain this quite often to patients during phone calls or when you're conducting any type of outbreak investigation when it comes to multi-drug resistant organisms. But colonization occurs when a microorganism inhabits a specific body site, such as the skin, but don't cause signs and symptoms, right? Now, what are the differences between signs and symptoms? Like when you say a patient has this certain sign or a patient feels this certain symptom, what would you say is kind of the difference between those two? Just from my clinical people out there. Shout out to my nurses. Okay, here we go. Signs are physical symptoms, and symptoms are what patients feel, right? Yes, we have redness is a sign. Symptoms are felt. Very good. So symptoms are subjective and signs are objective. So signs are something that you can clearly see. A patient that comes in with a 101 fever, hey, I feel warm or I feel cold. That's the patient. I've had chills, right? That's a symptom. A sign is that fever that lets us know, oh, hey, they have a fever. That is a sign. That is something that you're actually able to assess. Is there, like they said, is there redness? Is there swelling? Is there pus? So those are some of the differences between, signs and symptoms. Next, infection. An infection is clinical signs of illness or inflammation. For example, localized pain, tenderness, redness, warmth, swelling, pus, fever due to tissue damage caused by the microorganism's invasion, right? Back to infectivity, remember when we went over that vocabulary? The CIC exam, just they do not like to hold hands. They expect for you to just be very familiar. And a lot of people who work in infection control do have a nursing background. So when it comes to the clinical aspects of the exam, if you're an epi who doesn't have any clinical training or clinical background, it can be a little bit difficult. And some chapters you may need to read once, twice, or even 3 times to make sure that you're understanding. For me personally, I had to read a lot of the indwelling devices because I used to see them in the ER. Like I knew this patient had a Foley and I knew what that was. But, like telling the difference between, a PICC line, central line, it's like that information doesn't come to me immediately because I don't have a clinical background. And so keep that in mind when you're studying. And especially for those of you who do have a clinical background, there may be some chapters that you really, that you may not need to read because you've already done it. It's part of your training. You've known it for years. So trust yourself and take your practice exam and let that first practice exam guide you in what you need to focus on. And this is just a picture. I like pictures because, a picture's worth 1,000 words. And so you see here colonization, you have the pathogen that's just chilling. It's just, it's not bothering you. You're not bothering me. We're just friends. We're just colonized. And then you have infection where you have tissue damage and disease. It's no, we're no longer friends. You're giving me problems. And so this is really, these are two concepts that are important to keep in mind. So principles of microbial pathogenicity. So This first question, what is the measure of a microbe's ability to invade and create disease in a host and is determined by characteristics that relate to the favored site of invasion, disease induction, and avoidance of host resistance? I'll give you a clue. We've already seen the word once before, and it's just one word. We have a pathogenicity, we have an infectivity, we have a virulence, another pathogenicity. All right. Okay, the winner is Miss Carrie Harder. Everyone, let's give it up for Carrie Harder. Oh wait, no, I apologize. Elizabeth, Elizabeth Rowan with virulence. It is virulence, that is correct. Okay, so the initial element in virulence is the ability of an organism to survive in the external environment during transit between hosts. The answer was on the slide. But I didn't say that because I like to trick you guys. It's fun for me. It keeps you engaged. Okay, and so yes, the initial element is the ability of an organism to survive in the external environment during transit between hosts. If a pathogen is not able to survive outside of the host, that little guy has no hope of ever infecting anyone else. And so, for example, Mycobacterium tuberculosis possesses a lipid coating in its cell wall, and it collects, dried up proteins from sputum to protect against death by drying air. Right? Pseudomonas has the capacity to extract minute quantities of nutrients from water, including dead microorganisms, and survive in aqueous environments for months. And C. diff can turn into a spore, which is very resistant to drying, chemical agents, and heat. So those are the kind of elements that are going to allow these pathogens to survive out in the environment to be able to infect other people. Now, the second element is mechanisms for transmission to a new host. So some bacteria possess mechanisms of motility, right? Motility meaning movement, such as E. coli. So E. coli has a mechanism of motility which allows them to ascend a flowing stream of urine from the urinary bladder to the kidney and cause pyelonephritis. So here's another medical term, pyelonephritis. Pyelo meaning pelvis, basin, neph meaning kidneys. And what is itis? Itis, what does that mean when you see endocarditis? Oh, yes, you guys are just so beautiful and so intelligent. Everyone put inflammation. It's just inflammation down the line. This is wonderful. Yes, correct, inflammation. Very good, very good. So pyelonephritis, right? Inflammation of your kidneys. It is not fun. Pop quiz, what is one symptom of pyelonephritis, or what is something that, physicians always look for if a patient may have pyelo? Low back pain, yes, yes. Painful urination, yes. Dysuria, flank pain, right? CVA tenderness. Your physicians are gonna hit, you know, place their fist on that back to see if you have any CVA tenderness, costovertebral angle tenderness, and sometimes hematuria. Very good, very good. So survival times of pathogens. So we have our pathogens. Staph aureus can live from 7 days to greater than 12 months. So that's a strong gram what organism? You only have two options. Very good. Elizabeth, you are killing it today. Gram positive, very good. Clostridium difficile can live for greater than 5 months. Norovirus, 8 hours to about 2 weeks. And so this comes back to, making sure that they're able to live outside of, in the environment. So exotoxins versus endotoxins. So this is important because they explain this in chapter 22, and then I feel like for the remainder of the times when they come up in the books, they're kind of expecting for you to be familiar with the concept. So an exotoxin, they're proteins produced inside pathogenic bacteria, most commonly gram-positive bacteria, as part of their growth and metabolism. The exotoxins are then secreted or released into the surrounding medium following lysis. And what is lysis? For my bio. Yeah, so the cell breaking, correct. And endotoxins, listen, this I always found this like this always made me feel some type of way because endotoxin makes me feel like they're on the inside and exotoxin makes me feel like they're on the outside. But just remember this picture and it'll help you, okay? Don't just go by the roots. Okay, so endotoxins are the lipid portions of lipopolysaccharides that are part of the outer membrane of the cell wall of gram-negative bacteria. The endotoxins are liberated when the bacteria die and the cell wall breaks apart. Exotoxins exits the bacteria. Very good, Elizabeth. That is beautiful. Everyone say with me. Exotoxin exits the bacteria. Okay, wonderful. Next slide. Okay, so here we have a chart that kind of helps to break it down a little bit more. So for exotoxins, um, primarily gram-positive, proteins are secreted from the cell. They have a high toxicity. You're going to want to think cholera, tetanus, botulism, and then for endotoxin, mostly gram-negative bacteria. They're part of the cell. Low toxicity, think of meningococcemia and sepsis. So endotoxins possess the capability of interacting with the host system to set off a cascade of responses that can induce fever, swelling, vascular leaking, pain, and shock, such as the complement cascade and cytokine release. Yes, well, we don't need to dive into cytokine storms right now because we don't have a lot of time left. Oh my goodness, loose. Get it together. Okay, the cellular immune system. So the cell-mediated immune system, it's induced, mediated, or regulated by T lymphocytes and mononuclear phagocytes. I love my T lymphocytes because they just have such a beautiful growth journey. For those of you who don't know, they have a great little description in this chapter. But if you have taken immunology, I'm sure you guys can appreciate just how much T lymphocytes love us and how they mature in the thymus and how difficult of a process that is for the T lymphocytes. For the antibody-mediated humoral immune system, they gain the ability to recognize virus-infected cells and adhere to and kill them. So that's going to be your CD4, your CD8, which have cytotoxic or suppressive factors, meaning that if it's cytotoxic, it kills cells in which viruses are replicated and they can sometimes kill tumor cells. Suppressor CD8 cells control the intensity of T and B lymphocyte activity by suppressing their reproduction. That way you're avoiding an excessively robust response that might be harmful to the host. So your CD8, your CD8 cells are trying to help you out. And then your B cells, of course. These are also referred to as the innate immune system versus the adaptive immune systems. And then cytokines, cytokine storms, cytokines releases. These are all really, it gets messy with cytokines. So we're not going to dive into it. We're just going to mention it right now. So they're substances that have specific structures and biological activities. Okay, we have a matching game and we got to do this quickly because we have 5 minutes and we still have a couple more slides. So, okay. Let's do it backwards this time. Actually, no, we can't do it backwards because I didn't do the arrows like that. So IgM, which one does IgM match with? Early immune recognition and response, first reacting immunoglobulin. Very, very good. Yes. And the way you're going to be asked about this on the exam, the way they're going to bring these immunoglobulins in is they're going to attach them. You may have specific questions about the immunoglobulins, but they typically link them to a disease. So for example, they'll talk about hepatitis A, they'll talk to you about hepatitis B, and they'll try to ask questions around that type of immune response. So for IgD, which one goes with IgD? So it functions in later immune responses. Yeah, IgD, it's one that we don't really talk much about, and I really wouldn't spend too much time worrying about it. It's not as important as the other ones. Sorry. Love you, but we don't need you. We need you, but not for this test. Okay, so for 3, IgG. Oh, wow, look at this. It's just like, yes, yes, yes. Everyone put D. Everyone knows IgG. Yes. Late occurring immunoglobulin in an immune response and is the longest lived. And then IgE. Okay, we have a lot of A's. Yes. Principal allergy-induced immunoglobulin. And lastly, IgA. Very good. Very good. Effective in preventing virus infections of the respiratory tract and intestinal mucosa. We could talk about measles and, soup de carotte, which increases IgA production, but we do not have time, so we need to move on. The phagocytic cell system. Okay. These two charts, and I chose charts because I like pictures. I would really recommend that you guys review these, especially if you haven't taken immunology in a while or you haven't, reviewed the immune system in a while, because they do ask you sometimes questions specifically about the cells. So we're not going to go dive into this right now because we don't have enough time. Okay, pop quiz time. So the most immediate post-operative surgical site infections beginning in less than 24 hours from incision are caused by A. Staph aureus, A. Streptococcus pneumoniae, C. Streptococcus pyogenes, and D. E. coli. Mm, 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 mm. Okay, we have a lot of A's. We have a C. We have one C. Okay. All right. Well, Mr. Michael Drennan, look at you. Yes, correct. You are the winner. Streptococcus pyogenes is right. They actually secrete an enzyme that enhances the spread throughout the tissue, so it's able to move pretty quickly. So the answer is C for that one. And then for 2, what bacterial factor or structure facilitates bacteria implanting on plastic devices? We have a cell wall, an exotoxin, an endotoxin, and a glycocalyx. Oh, that was Elizabeth Starney for that previous question? Yes, Elizabeth, look at you. You're a queen. Thank you so much. Okay, so we have a lot of D's, some C's. Okay, so it's D. So the glycocalyx, it's like this slime layer, right? It's like this slimy capsule. Yeah, not necessarily a capsule, but it's like a slimy layer that facilitates attachment to certain bacteria of implanted plastic devices. And so that's very important to keep in mind for when you're taking the test. Okay, next one. Which immune marker represents, that's supposed to say past, I apologize, past exposure to disease? Yes, IgG antibodies are the antibodies that provide long-term resistance to infections after immunizations. Okay, so we're going to jump into our group member spotlight. This is the first one for this week, and we're right at the very end. And so our group member spotlight for today is Sebastian. And what I'm hoping to do with a group member spotlight is for us to get more familiar with everyone that's on the group. And so I'll just briefly tell you a little bit about Sebastian. He's in Miami-Dade County. He's one of my counterparts in HAI Epi in Miami-Dade County. He graduated from UF with his BS in biology, and he's actually currently pursuing his MPH at FIU. In another life, he says he would have been an astronaut, so that's really cool. He's not a fan of The Lord of the Rings or Harry Potter, which kind of hurts my heart a little bit, but that's okay. He's a fan of Game of Thrones, and he's not about Star Wars. His favorite workout is swimming, and his 2 favorite movies are Interstellar and Arrival, and then one of his biggest idols are Neil deGrasse Tyson. And so next week we'll have another group member spotlight. If you're interested, let me know. Otherwise, you'll just get an email from me asking you if you would like to participate. And yes, let's go into our week 2 assignments. So our action items for next week, we need to reach chapters 24, which is microbiology basics, chapter 25, laboratory testing and diagnosis, and chapter 26, antimicrobial resistance. Important chapters. Outline the chapters, make study cards, make sure that you get to know these chapters. I personally believe that the blue book is the most important book when it comes to preparing for the exam. It is the book that I read the most out of in comparison to the green and the yellow. And so just make sure that you have these concepts really well known and well studied by our next meeting. Optional homework ideas, this is just in case, you have a little bit of extra time. Try to read 2 chapters from the additional chapters reading list. And my tip would be to use your practice exam 1 to guide your readings. So look at what you did well in and look at what you did poorly in, and allow that to guide what kind of chapters you need to have a little bit of extra work on. Okay? And so that is it, guys. Does anyone have any questions so we can go ahead and close? We had someone say go Gators, Sebastian, by the way. Go Bulls. So that's what I have to say. All right, guys. Well, it seems like no one has any additional questions. So we'll be covering chapters 24, 25, and 26. There may be times when I won't be able to cover a certain chapter because of the just the sheer volume of information, but make sure that you're still doing your readings, okay? Okay, Tanya. Okay, go Gators. I get it. All right, guys. Well, thank you so much for listening in today, and I hope you guys have a wonderful weekend, and make sure you do your readings. And for those of you who didn't turn in your test, I got my eyes on you, and make sure you turn it in Monday. Okay, bye-bye.